Great talk. So thank you very much to our speakers. And Mike, you kicked us off, giving us an overview of what the treatments are there that are out on the horizon, as well as talking about the established therapies. Can I ask you a few questions at the start? The first one is about sort of taking a global perspective. We're very lucky to have these new therapies readily available, at least dupilumab in North America and Europe, but taking a global stance, how can we make new treatments available in other countries in low-income settings, thinking about the African continent, thinking about East Asia?
Thank you, Carsten. This is a really important question about how we make new therapies available in developing countries. We're very fortunate at the moment to have a pediatric dermatologist from Nigeria, Sharifa Khatibi, working with us for 3 years. And so I took the opportunity to ask Sharifa exactly this question. Are you going to be able to use dupilumab in Nigeria? To which Sharifa said, well, we have trouble even affording blood monitoring for methotrexate. So this really is a major challenge, how we are going to afford these therapies in developing countries. So methotrexate was their first choice because they could get it very cheaply, but the blood monitoring was a financial burden to them. So clearly, highly targeted biologics like dupilumab, tralokinumab are going to be out of reach unless we have some special program for these developing countries. I think this is such an important area.
Yeah, and it's something that organizations like the International League of Dermatological Societies potentially could think about, working with patients organizations as well in those low income settings. Just a follow-on question here. The only therapies that will be licensed under 12 will be the new ones, for sure. Does that matter, especially again for those low income settings?
I think in the low income settings, no, it doesn't matter because it's pragmatism as to what can be afforded. I think in other countries, it places pediatric dermatologists in a regulatory medical legal position where, from a regulatory point of view, we're supposed to prescribe licensed therapies first in order to be protected, and then only use off-licensed therapies as second line. So that's another important question that we need to get some resolution to.
Yeah, thanks, Mike, for that. Carol, can I ask you, and then after that, Sandipan, just very briefly, what your perspective is thinking about, these high-cost medications, novel therapies, the issue around reimbursement and licensing that Mike touched on?
Thank you, Carsten. Yes, the sentiments that were expressed by the Nigerian fellow, Dr. Cox, Nigerian fellow, will apply in this country as well, in South Africa. But of course, we are a little better off than the Nigerian setting. But such that we've been told that we will have access to at least Dupixent in a short while. It's likely going to be in the next year or two in South Africa. So there is at least that in the pipeline. But it is true that there will be issues with reimbursements. And I know that only a few patients will get access to it eventually.
Great, thank you. Yeah, Sandeep, just briefly.
Yeah, thank you, Carsten. Yes, it is a challenge, definitely. And, DCGI means Drug Controller General of India and CDSCO, the regulatory bodies in India have not yet given permission to do dupilumab, but Sanofi Genzyme, I understand, is, trying their best to get it, licensed in India. And so far, the kind of information I have been given that they are going to get it through maybe in another 1 year or so. There is a small section of people who can afford. And for your knowledge and information, that we have come up with the first study on dupilumab with 25 patients, which we published just 1 month ago in Indian Journal of Dermatology. That indicates that some people can definitely afford, who have got very intractable atopic dermatitis, which is not controlled. They can go to any extent, for their children. And, this is the common psychology everywhere. I think that parents, they don't mind spending extra bucks for their children, whatever may be the cost. Their cost is not a factor. Their children's, quality of life and the disease to get under control as early as possible is the main concern for them. And for some section of patients who definitely are not going to respond to even cyclosporin or methotrexate, they are ready to spend that amount of extra bucks. But yes, definitely it is a big challenge because the cost is really very prohibitive. But I understand in the days to come, the pharmaceutical companies will also consider about that, and licensing authorities will also put some, bar on the cost of it. That can solve the problem.
Yeah, so yeah, thank you for that, Sandipan. Amy, we had some questions for Carol as well.
Yeah, I'd like to actually address the entire group, because I think that the question of skin of color and darker skin and practical management is one that we all face. So we'll start with Carol. Dark skin, sometimes it's very hard to see the inflammation and to follow the inflammation. Of course, we can be talking with our patients about symptoms and all, but do you have any practical tips on how to best visualize the erythema that one can see, particularly as the skin gets darker? We find that challenging.
I'm sorry I'm laughing, but I can't offer any tips. I think just because I've lived in this environment and my eye is so used to looking at dark skin, we can tell, we can pick up the erythema in the background of dark skin, but I would have to admit that it is not the easiest thing to pick up. But no, I can't think of any tips. I just think a trained eye will be able to pick it up.
And that's right. I mean, I certainly know that I come out thinking someone's very inflamed, and the student who's gone in says, I don't see any redness. So exactly. I absolutely agree that some of that is just experience. Anyone have any other tips? I know this is something we often discuss.
Hi, Mark here. I agree. I mean, we see a lot of Indian patients, skin type of 6 as well. And sometimes I can't use the erythema as a marker of severity. So I use the other markers like scaling, lichenification, the thickening and induration as a marker of active disease, and excoriations as well.
Yeah, well, certainly one of the markers that we often see with darker skin is post-inflammatory pigment change. Now, Carol, you mentioned the effect of steroids in sometimes leaving decrease in pigmentation, but in my own experience, it's really primarily the effect of the inflammation of the atopic dermatitis itself that leaves that behind. And I wondered what your experience is with post-inflammatory hypopigmentation, but also depigmentation. We often see depigmentation that looks like vitiligo, particularly on hands, for example, which then is quite persistent. Can you talk a little bit about the post-inflammatory pigment change, and also perhaps the pityriasis alba that's often associated?
Sure. So let me just also clarify something else. So what we've noted here is that when patients have eczema, atopic eczema, then the normal mode of healing is post-inflammatory hyperpigmentation. We actually use that and contrast it to psoriasis, because when psoriasis heals, lesions of psoriasis lose color, but the ones of atopic dermatitis, there's accumulation of color. So the depigmentation is not common when it comes to just the natural healing of atopic eczema in the skin that I tend to look after. But then when you use steroids in eczema, that's when we see loss of color. So this is answering your first question, Dr. Pala. And then now when it comes to pityriasis alba is another, I would say, maybe another contrast to what you guys are experiencing, particularly with what Mike was indicating. There is when there is depigmentation or hypopigmentation, that's when we know it's pityriasis alba, because ordinarily we don't even pick up pityriasis alba. So the only way we pick it up is when they've lost color, as opposed to a gain of color.
That's very interesting. Sandipan, do you have any different experience in India?
Yeah, thank you, Amy. I think this is a very important aspect while treating or handling cases of atopic dermatitis. In a country like India, where we see type 2, type 3 skin in extreme north, and we see type 4, type 5 skin in extreme south, and on both east and west, we see both type 3, type 4, as well as type 5 skin. So all different types of skin we see in different parts of India. And having said so, I must say that, we see mostly, I agree with Carol that by and large, atopic dermatitis heals with hyperpigmentation. But there are cases where we see atopic dermatitis healing with hypopigmentation, particularly when treated with topical corticosteroids and particularly potent topical corticosteroids, that steroid-induced hypopigmentation that persists. But our impression is overall, by and large, that certain diseases heal with certain types of pigmentation. Classically, lichen planus heals with hyperpigmentation. Psoriasis heals with hypopigmentation. But here there is a disease, atopic dermatitis, which can heal either with hypopigmentation or hyperpigmentation. So this is atopic dermatitis is really a very strange disease in many ways. Here again, as far as the healing is concerned, these can follow or go in either ways, both hyper and hypopigmentation. And let me tell everybody here that it is the most challenging area, that even after the dermatitis goes, the patient and the parents, they are not very happy with the hypo or hyperpigmentation. So quality of life index, even after treating the dermatitis itself, that is not brought under total control unless and until you are able to do something about the pigmentary changes.
Now, so the very important point that we must manage expectations up front about the fact that patients may have long-term pigmentary change that we can't control as well as we can control the inflammation. Let me ask Mark and then anyone else too, since we all have experience, if you have any other comments about the pigmentary changes.
Well, it's a couple of questions after Mark from Ayuki and from Mike as well.
So I do see that post-inflammatory depigmentation in a handful of Chinese and even Malay patients. So they are skin types 4 and 5. And it looks very much like vitiligo. And it classically, as Amy said, likes to appear on the hands, but also on the feet as well. So these are the sites that they tend to get it, and it repigments in that perifollicular fashion as well. So it looks very much like vitiligo. And interestingly, the patients are not concerned about the depigmentation at all because they are so affected by the eczema that they never ask me to treat that depigmentation. Whereas a patient with vitiligo will come in and is extremely depressed about the vitiligo. So so I'm really interested in why some patients develop this depigmentation.
And always with severe disease.
Mostly severe disease,
Yeah.
yes. Yeah.
All right, Valeria.
Yes, I just wanted to add that here in Brazil, we also see a lot of African descendants and Asian skin as well. And I agree with Mark. I think the patient usually gives us hints when he's having, a flare. Usually it complains about intensity of the itch. Lesions become wet, despite the fact that we cannot evaluate the erythema like in African patients in comparison to Caucasian patients. So I think we have to listen also to the patient's complaint as well.
Agree. Okay, Mike.
Can I just go back to the scoring of erythema? I think Mark made a point that's really valuable, which is something that I use a lot. So our clinic at Sheffield Children's Hospital is a bit like United Nations. So we have children from all over the world. So it's that sort of whole palette of colors from all the different skin of color. And I do exactly the same. So I'm referencing, for example, the easy, I add one score for the erythema, but then I'm looking at all the other components and thinking, well, what would I expect the erythema to be in the context of that? And then I look at their NRS and I think, well, what would I expect the erythema to be in the context of that? So it's a sort of lot of cross-referencing all the time as we're moving from all the different colors of skin. Yeah, I agree. I think that's really important. But as you said, Amy, it just comes from experience. You get a gut feeling of what it is just because you've seen so many.
But Amy and I discussed in the past potentially setting up a task force around the severity scoring in people with skin of color. I don't think there has been enough work that's been done on that. I think there's a real niche here for potential research. But Carol, you wanted to come in as well.
Just going back to depigmentation in pityriasis alba, but more depigmentation with atopic eczema, or how we viewed it was that vitiligo and atopic eczema tend to coincide. I'm not even sure if this is documented, but this is our experience anyway. So I'm just trying to say, I have seen atopic eczema and what I viewed as vitiligo. So it very well may have been this unusual depigmentation that is maybe a form of, I mean, what my Mark has been observing. I just never thought of it as a depigmentation. I've always thought of it as just pure vitiligo, but together with atopic dermatitis.
So Carol, I've certainly seen both where patients have atopic dermatitis and they also have vitiligo that looks like classic vitiligo. What I think is related to the atopic dermatitis is this vitiligo-like process on the hands and feet that is particularly with severe disease and is not your typical vitiligo. You don't see it elsewhere in terms of round vitiligo lesions. And I think that is something that is distinguished. Carol, you talked about nummular dermatitis. You showed pictures with nummular dermatitis. You also mentioned the increase in follicular dermatitis seen with darker skin. These are a little bit more difficult to handle. I'm just going to open up to this experienced team. Any particular tips for trying to clear nummular dermatitis more readily, or the follicular element?
Now I experience in London, and we do have an ethnically very diverse population, similar to Sheffield. We have a lot of children with black skin or Asian skin. Follicular and discoid eczema respond less well to anti-inflammatory treatment, be it topical or systemic. So certainly with the topical treatments, you have to just go up one class usually to get a similar response, even if someone who presents otherwise in a similar way with white skin. I don't think we've seen any research being published on the response to systemic therapies in people with these different phenotypes, unless someone else has seen anything in the public domain. But I think that's worthwhile doing, just looking at the, how potentially differently discoid versus follicular versus classical predominantly flexural eczema response to systemic therapies, and whether there's a difference there.
Sure, if I can go in there, it is our experience as well that with nummular eczema, when I teach the students, I tell them that it's more intractable to therapy than the ordinary eczema that we see. So I tend to also teach them the same, that if it is nummular eczema you are dealing with, then you have to go potent steroids before you start with potent steroids and keep going down. But because you'll find that a patient has got eczema, normal eczema elsewhere, and they will treat with maybe a mid-potent steroid and treat with it, treat both the nummular eczema lesions and the non-nummular ones. But I tell them to really focus to use potent ones for the nummular lesions, because it's intractable to therapy, and certainly for the follicular ones, we will go straight for the potent without even blinking an eye for those two. In terms of the research, I also haven't come across, but it is our experience that it is difficult to treat. Those two are difficult to treat.
Come over here that both the nummular eczema as well as follicular variants of atopic dermatitis are definitely difficult to treat. And I agree with Gaston that there is not enough data or literature on that. At the same time, I must say that in both the cases, the problem is that when you treat with topical steroid, whether mid-potent steroid or moderate or super potent steroid, in case of nummular eczema, the eczema may subside after suppose 1.5 months or so, but there may be development of a post-inflammatory hypopigmentation because of steroid, a halo of hypopigmentation around the nummular lesion. That is, in fact, more cosmetically disfiguring for the patient as well as the parents. And the same thing happens with follicular variant. over the follicular area, when you apply the steroid, mid-potent steroid or potent steroid for 2 to 3 weeks or even 4 weeks, the follicular lesions, they disappear, but they leave behind post-steroid hypopigmentation. So these are, difficult, things for the physicians, for us, as well as, disfiguring for the patients, as well as not acceptable to the parents.
Sorry, Carsten, can I add to that? It's what I said earlier. One other thing we do more is then add wet wrap therapy to treatment of nammular eczema, which I don't know if we will be talking about wet wraps in this meeting at all, but I'm just trying to say also to just accentuate the effect of the potent steroids in nammular eczema as such. We use a lot more wet wraps.
Yeah. No, we would do that in the UK as well. Mark, just a very brief comment from you, and I think, Amy, it would be good to then move on to the infections and the microbiome.
Yes, I think that's my plan. Go ahead, Mark. Okay,
I just wanted to say that I do have some success using phototherapy for both nammular eczema as well as follicular eczema, like lichen spinulosus. And I mean, because I'm treating a lot of skin types 3, 4, and 5, so it's quite safe. And I do find that, after about 6 months of phototherapy, I can control their discoid eczema as well as some of the follicular eczema. But there are some of the darker skin patients with these, very follicular papules, but they're not very bothered about it. Somehow it's a bit, I think of it like keratosis pilaris, it's follicular over the arms, but a lot of patients are not bothered by it. So if they're not bothered by it, I just leave them alone.
Yeah, we've made real breakthroughs over the last few years in our understanding of the organisms that live on the skin. So thinking about the bacterial microbiome as well in the context of atopic dermatitis for today's meeting. We talked about the skin, but what about the gut microbiome, Helen? Is that altered in atopic dermatitis?
Yeah, that's a great question. So yeah, as well as the skin microbiome, studies have shown that the gut microbiome is altered in atopic dermatitis. And it's thought that through the so-called gut-skin axis, that these changes in the gut microbiome may in fact alter the skin and potentially alter atopic dermatitis. So it's been shown that in AD, children have increased levels of certain gut bacteria, such as Faecalibacterium, certain Clostridia, and Escherichia. And some of these species have been shown to be pro-inflammatory in the gut, so suggesting potential sort of mechanisms for how these gut microbiome changes may lead to more pro-inflammatory immune state. The inquiring about tolerance study showed that even in infants as young as 3 months, that those that have an increased abundance of a certain Clostridia species are at high risk of developing AD. And in contrast, studies comparing the AD and healthy skin gut microbiomes have shown that in AD, there's reduced levels of certain other species that may be anti-inflammatory. So, for example, species that produce short-chain fatty acids, which have been shown to be anti-inflammatory through expansion of T regulatory cells. These have been shown to be reduced in AD compared to healthy skin, healthy children.
So that's very interesting. So the gut microbiome has got this educational role, if you like, especially in early life. With what you've just said, is there then a role for pre or probiotics as a potential preventative or as a treatment in established atopic dermatitis?
Yeah, so this has been looked at. There's been some trials using pre and probiotics in children with atopic dermatitis and in women during pregnancy. And these have been shown to have some potentially therapeutic and even preventative effects. And mostly the species used are lactobacilli and bifidobacterium. And it may be that these agents sort of interact with immune cells in the gut to kind of mediate the Th1, Th2 balance, and perhaps through expansion of T regulatory cells as well in the gut. This may be what sort of influences the development or the severity of atopic dermatitis. And it also kind of raises the question of the role of diet in atopic dermatitis, with diet potentially mediating the gut microbiome and how this may have a knock-on effect.
Yeah, so we know that lactobacilli and bifidobacteria seem to be the good guys. I mean, from my experience, I don't know what others do in their practice, but it's very difficult to hand on heart recommend a product, because these studies are so methodologically so diverse. You know, which one do you go for? Parents will obviously want to, well, which of these 150 different ones that are on the shelves of our stores should we actually go for? But you know, maybe just open it up to a few others. Mark, if you see a pregnant mum in your clinic in Singapore, she's already got one child with eczema, you're seeing that, you know, and she's seeing you with this other child, and she says, Dr. Kaur, what's the one thing I can do during pregnancy? Do you recommend probiotics or not?
And I mean, as has already been said, I think the evidence is really, you know, difficult to prove. It's safe, so I'd say if they want to take it, please go ahead. But you know, I do tell them sometimes, you know, when the child is born, number one is maybe you would want to do a bit of prophylactic moisturizing before the child develops eczema. And whether the child should take probiotics, I think some studies have shown that it works, as Helen has said. But I will not substitute it for the creams, and they will still have to use the creams for the child. So that's what I'll tell parents and children as well.
Yeah, I mean, the evidence suggests that once you've got established atopic dermatitis, skin inflammation, then probiotics unfortunately don't really make a difference anymore. So it really is about priming of the immune system, isn't it, perinatally, and what goes on during pregnancy is important. Sandipan, you talked about skin infections as well, of course, you know, from your perspective. Just one question that we've got here was about how common is eczema herpeticum in skin of color in your Indian setting?
This is a fantastic question, Carsten. This is interesting that though we have a huge number of population of atopic dermatitis, by and large it is 7% of the pediatric population, which is quite huge because the children population worldwide, the largest children population is in India. So though the percentage of atopic dermatitis 7% looks smaller than American or Scandinavian percentage of 22 to 25%, but in terms of number of patients, we have a huge population of childhood atopic dermatitis. Here, the eczema herpeticum somehow over my 30 years of experience in this field, I have seen very less, and we have been always inquisitive about it. And of late, a study is underway about the FLG mutation, filaggrin gene mutation, in our institute, where we have found, and as well as some other institutes in India from 4 different parts of India, and we have been seeing very interesting observations we have made that FLG mutations, some very typical mutations we have found, which has not been reported as of now. I cannot tell exactly the details of it. Maybe after 1 year, I will be in a position to say. And in some patients with a type of filaggrin gene mutations, they have more propensity to develop, eczema herpeticum, while others are not. So though we see herpes simplex quite commonly in children, though we see atopic dermatitis are very commonly, but in my practice over last 30 years, probably I have not seen even 30 cases of eczema herpeticum. This is something which is very strange. It is not very common in our population.
Yeah, that's interesting. Is that the case for, again, thinking about South Africa and South America and Singapore as well? Or what's your experience? Maybe Valeria, do you want to come in there?
Yes, here in Brazil, I think we have more eczema herpeticum, especially during the summer time. I think sun exposure is a really big trigger for that. And in comparison to what kind of patients would be more prone to have those eczema herpeticum, it's difficult to say because we still don't have skin barrier studies enough to attach, the fragility of skin barrier and eczema herpeticum. However, these are the ones that usually have more severe disease that exhibit those viral infections. And it's a problem because when they are, UVB narrowband is a very useful treatment. And we always tell the residents and the medical students that a very precise previous history of previous herpes simplex infection is really relevant to avoid such reactions after UVB narrowband.
Yeah, no, thank you for that. Carol, anything from your end? Is a very similar experience to South America?
Yes, certainly. It's actually the exact opposite to Dr. Dar's. We tend to see it a lot. It's the second commonest secondary infection to impetigo in our world. And they can be quite severe. As I speak, I've got 2 patients in the ward who have just been admitted just because of that. And it's eczema herpeticum affecting the face, going down the neck. It can be quite extensive and it can be quite devastating for the family. So we see it quite a lot.
Yeah.
Yeah, Mark here from Singapore. So I think we see quite a lot of eczema herpeticum as well. I think in a month we get at least a couple of cases in. But most of them have only 1 episode and that's it. But there's a small percentage of them that get recurrent eczema herpeticum. So, you know, I've always wondered, you know, when's the threshold to starting them on prophylactic acyclovir, and how long would you go for?
So you do see recurrent infections quite a bit as well?
Yeah. So in a handful of them, probably less than 10%, we get a recurrent eczema herpeticum.
Yeah. So
I tend to put them on prophylactic acyclovir for about 6 months to a year before I.
That's interesting.
Instead, yeah.
We have a question about using topical steroids or topical anti-inflammatory treatments in secondary fungal infections and atopic dermatitis for Sandipan in a moment. But Mark, would you have concerns using topical steroids? You know, the residents we work with always ask, you know, a bit anxious about using topical steroids on infected skin. So thinking about eczema herpeticum first and topical anti-inflammatory treatments. Do you stop topical corticosteroid treatment in the affected areas, or would you continue? Because clearly there is an important inflammatory component in eczema herpeticum. I
agree. So if I see eczema there, I would not stop the topical steroids. So I'll start on systemic antivirals. But if there's visible eczema, I will continue on the topical steroids as well. Yeah. If there is secondary bacterial infection, I would add on, you know, systemic antibiotics as well. Yeah. I guess for the fungal part, if it's pure tinea, let's say tinea cruris, and there's no eczema there, I would switch to a pure antifungal. But sometimes,
that's interesting. And Sandipan, would you do the same, or would you, if you have a strong inflammatory component within the area that's secondarily infected with a fungus, would you use a topical corticosteroid as well, alongside an oral antifungal, I suspect?
You know, the principle what we follow is that we over the eczematous area, if we see, which we quite often see, the superadded tinea or dermatophyte infection, we never allow the patient to apply corticosteroid over that area, because the tinea goes into kind of tinea incognito formation. We discontinue steroid. We give a pure antifungal, because we know most of the antifungals, they have got strong anti-inflammatory property as well. And in the meantime, we just give moisturizer, you know, to control the xerosis part of the eczema. And oral antifungals we add, so that is able to control the fungal infection of any type or any severity within 2 to 3 weeks. That is not a long period in terms of treatment of atopic dermatitis. So after 2 to 3 weeks, again, we can give topical corticosteroid when the fungal infection has cleared. But during the active fungal infections, we don't allow topical corticosteroid to be applied on the same area.
Thank you for that.
Let's go ahead and round this out with a few questions about Valeria's excellent presentation. Valeria, I wonder if you could just start us off with this concept of shared decision-making, AD consensus, and tell us what your experience is with the impact on caregivers or patients to adherence to treatment and then access to medications through this process of shared decision-making.
Yeah, I think one of the relevant points of those, associations and educational programs is really to reassure that patients and caregivers are offered opportunities to express their voice And I think access to medication is really tough, like here in South America and Africa or some parts of Asia. This is still very hard to get. And I think if those associations work on this issue, it could be a very powerful tool to achieve access to medication. This is one point. Second, I also ask, how powerful is the consensus to achieve patients? I think for physicians, it's a good tool, even to reassure that you're performing the best treatment options for them. But for the patients, I don't know if we have, I think we need studies to evaluate how useful those tools that we are using are for the patients and caregivers. I would like to listen to other opinions here as well.
Yeah. So any other experience with shared decision-making, these opportunities of education, and how they can help both adherence and the ability to get the right treatment?
Yes, whenever I see a patient of atopic dermatitis of any severity, by and large, since I mostly practice in pediatric dermatology, so I always discuss with the parents about the disease and the outcome of treatment measures. And always I tell them that they should be mentally ready for a long drawn battle. This is which I have found that something many of our colleagues have not told them, that a little bit of eczema, they just give steroids, just write a prescription and leave it like this. And the parents expect that this has disappeared, it's not going to come back. I always tell them on the very first day that, look, this is a disease which is very chronic, and the course of the disease is punctuated by remissions and relapse. And you should be ready for next 5, 6, 7, 8, or even more number of years for repeated attacks of this eczema. And this is a long drawn disease. And all these things, when they are told in a very methodical manner with a lot of, empathy and positive attitude, parents, they understand and they follow the treatment, and compliance automatically becomes very good. I always try to give the best possible positive, outlook to the patients, but keeping the practicality also intact. I don't, give them the kind of any rosy picture for the disease, but at the same time, I try to give them a positive outlook about the disease.
Let's open to the entire panel the question of ADD, ADHD, which has been shown in several studies to be increased in atopic dermatitis. And we certainly also see some of the signs of ADHD in our patients as well. What's been your experience in terms of whether early treatment of the ADD, ADHD helps the atopic dermatitis, or vice versa, that better control of the atopic dermatitis can help with some of the symptoms of ADD, ADHD? Let me just open that up.
Amy, can I pick up on that? I see it mainly the reverse, so that treating the AD very actively, very, very early can help the ADHD. And this may well be because we're switching off the inflammation that's affecting the brain, affecting neurotransmitters and affecting brain development. And I think it's one of the arguments for very early intervention in AD and having new therapies licensed down to 6 months. So I think it's a very important area for research.
Now that would take a prospective study with a large enough number of people that we would have several cases come out in a control group. But yes. Other comments about your experiences?
Yeah, I would like to come over here that this is something again which is very common. I have been seeing it, over the last 10 years, I must say, that many patients with AD and ADHD, it is immaterial whether they have got mild disease or the moderate disease or the severe disease. I think ADHD does not go hand in hand with the severity of atopic dermatitis. But yes, I agree with Mike that by and large, with treatment, good treatment of atopic dermatitis and good counseling of the parents as well as the child, ADHD can be nicely controlled. And it is very interesting to note that, some of my parents, they have come for the first time and saying the doctor, look, my child has been diagnosed at ADHD and he has developed some peculiar skin rash. Then I find that they have got that atopic dermatitis. So they have first been diagnosed by a pediatric psychiatrist or their pediatrician that their children have ADHD. Then they come up with atopic dermatitis. This is also a very interesting observation, at least for me. And, that has become easier for me to convince the parents there.
Yeah, but we do have to keep in mind that there are criteria for ADD, ADHD that go well beyond things like inattention and fidgetiness, which are certainly parts of what we can see. I think the question is, do we, through vigorous treating early on, affect the brain, improve or reduce the propensity towards developing true ADHD? But certainly, if we can improve the atopic dermatitis itself, it doesn't hurt, because that is a major distraction for patients and can also lead to some of the signs. There's no question. Any other comments?
Yes, I think another point to think of is how are we affecting the development of the brain in terms of increased exposure to topical steroids in children? This is something that really intrigues me as well. So I think we need to study more. And
antihistamines, of course, there was one major paper that found an association of use of antihistamines and the occurrence. And so I think we do have to keep in mind our treatment regimens, especially early on systemic medications. Let's move on to just ask one more question, and that's about the use of phototherapy, which of course is something that is universally available, and how that plays a role now in our treatment, especially with the availability of newer agents coming out. We talked about some difficulties with getting dupilumab, but any thoughts on the combined therapy of a narrow band UVB and dupilumab in pediatric patients?
I mean, if I can come in there, Amy, phototherapy is no doubt a good treatment, and unfortunately very, very under-researched. So there's so little evidence there, especially in the pediatric atopic dermatitis context, but even for adults. We've recently completed a Cochrane review on phototherapy in atopic dermatitis, and I know we as clinicians know that it works. The conclusions are rather weak, the punchlines from the Cochrane review, so which was disappointing for us. And I think there is some more work that can be done also in the context of home-based phototherapy. So as part of the pandemic, certainly in the UK, there's been increasing interest in setting up home-based phototherapy in National Health Service departments, something that is already available in Scotland. The burden on patients otherwise, if they have to travel with their child in the pediatric context to a department at least 2, if not 3 times a week, for something like 10 weeks is a massive burden. So that's something to keep in mind as well. I think it's unlikely. I personally would combine phototherapy with dupilumab very often, partly because of that burden. If someone is not responding adequately to dupilumab, I'm more likely to travel to another systemic therapy rather than combining the two. But that wouldn't be for safety considerations. Wouldn't have any safety concerns about that combination of dupilumab with phototherapy.
What about phototherapy itself in areas that where we talked about dupilumab's not going to really be an option? How much do you all use that? So let me just ask the question: what about narrow band UVB phototherapy? Especially with the high cost of dupilumab, does that remain a viable option? How much is it being used around the world?
So I use quite a bit of phototherapy in the children that I see. I feel that compared to immunosuppressives, it's skin directed and it's probably a bit safer, and especially for darker skin patients. And you are right. I think convenience, having that time to come for the phototherapy is usually the burden. And in Singapore, even though distance is not a problem, time is a problem because a lot of our kids go for tuition and they don't have time to come for phototherapy. The problem with the home phototherapy is that we can't get the big unit. So we only can get the small units where the probe is so small. So if it's for the whole body, I don't think it works very well. Yeah. So, but I do find that for those patients that I start phototherapy on, probably about 50% of them do respond quite well. But I need to treat them for at least 6 months to a year.
Valeria.
We have good response in the big centers where they have access to good phototherapy units. But we don't have this home devices. But only a good option here is because we have a big coast. They usually get much better in summertime. So we explore this season UV exposure. That's our experience.
Okay, well, let me just take this opportunity to close out this session by thanking all of our speakers for wonderful presentations, as well as a lively discussion. Certainly, atopic dermatitis is a problem that affects children worldwide. We all, as you can hear through this discussion, share so many of the same issues, and I'm looking forward to this time of the vigorous production of some new management options and a lot of sharing among this global community of tips for our patients with atopic dermatitis. Thank you all for joining.
Thanks so much.
Thanks.
Thank you.
Thank you.
Bye-bye.
Bye.